says about what is the patient, what is the accessibility of the care centers to the patient, what is the village size, and basically drill down upon these charts to get more details about the performance of the PHC. This chart shows more of accessibility of health center vis-a-vis the villagers and the size of villages. So this all application is based on a tablet which will work on offline mode completely and can be synced when when the connectivity is available to the cloud. So so being this is a mobile application, we can track the individual health worker, where is she, how long she is being giving care, and basically map out all those analytics and come up with all those analytics to basically show the performance, which you can see at the staff accountability. So these are the various analytics which are more about drug inventory, accountability of the patient, care delivery provider, as well as we have incorporated risk modeling in pregnancy to identify high-risk pregnancies. So that is all about us. Thank you.
Thank you, Mr. Anand. I've been told to really squeeze this session, so we'll take only 2 questions from the audience. I'll request Dr. Sumer to share his experiences. Yeah.
Very good afternoon, everybody. Good afternoon, and I'm happy to be here in this August gathering and panelist, and I'm wanting to share my perspective of I want to share my perspective as a radiologist, as a physician who has ventured into IT-centric part, which is teleradiology. And I want to share how we evolved and what are things which are very centric to Indian scenario, which we usually don't hear in most of the places. So I would begin with acknowledgement. There is no one correct answer to every problem. There has to you have to see the problem and kind of fit it. Innovation is important. So this is how radiology started. This is 1895. This was the first X-ray, and this is Mr. Ranjan. Radiology gradually evolved to films, and many of you who are from medical background, you might have, or even non-medical background, you might have seen doctors holding an X-ray film, looking at the sun and looking at the finding. Then it went on to the dark rooms. The radiology runs in dark rooms. You put films on a view box and you make a report. Then came the era of the workstations. You started to report on complex workstations in the computers, and then the internet interlinked it all, and maybe the radiologists grew smarter and their locations grew exotic. And even now the size of the device is getting smaller and getting more and more powerful. So there is a lot of talk on use of iPad for emergency reporting. So this is how things have evolved. So when I started teleradiology, my teleradiology practice in 2008, everybody asked me that, are you because everybody had a view that teleradiology is KPO, which is reporting for US. And everybody used to ask me that, are you reporting for an American hospital? So I told them that my concept of teleradiology is that you're reporting for, it is transmission of images from one location to another. That other location need not be US. Why don't you look at the requirement and the opportunity within the country itself? So, and that was the era when everybody started to talk about world is flat. Now you can have global work coming to India. Everybody was talking about teleradiology in the beginning with the perspective that Indian doctors would report for abroad. And classically people used to look at Indian market as people who can go abroad and work, and then they started to look at us like call centers. But I want to showcase a side of the Indian market which I'm sure you might have seen this picture in many of the presentations that today in the spending in the healthcare sector from the Indian consumer per se has grown. So we know that today in many centers in India, the healthcare access that the patient has to tertiary healthcare is less. But more and more doctors are trained in centers which use radiology as the evidence. And there is a physician shortage, and radiologist shortage is even more, acute. Now, I want to show a figure to you which is of, of very valuable interest, because people say US has radiologist shortage and their ratio to radiologist to population is 1 is to 10,000. In India, the ratio is 1 is to 100,000. And we have had, talks of people who say that Indian doctors would fill up the gap for the US, the lack of radiologists in US. I personally feel that probably we are not looking at the lack which we have in our own country. So this is how we started, and we started with, places which do not have a doctor, places who have doctors but do not have a doctor, radiologist for emergency. We even provided, places. There were places which had a radiologist but was not trained in musculoskeletal radiology. We had a place where they were a good radiologist but not trained in cardiac radiology. So we tried and we mixed and matched for different centers. So since 2008, this is the kind of presence we have. And we started with the India-centric approach, and gradually we got to know that even places like Tanzania, Mozambique, they had similar problems to us, so we could expand our client base to these places. What we
Doctor,
do is...
we have a time constraint, so just a time check.
I'll be very quick. So this is how we worked on that. We link these centers to a centralized server, and then we distribute work to radiologists. There are some problems which we face, particularly in India, that ultrasounds in India are done by radiologists and is governed by an act called as Prenatal Diagnostic Techniques Act. So ultrasound, which is a very, very useful modality for diagnosing acute abdomen, is somehow, we cannot do a tele-reporting on this because of the problem of sex determination in ultrasound. So that is an India-centric problem. Second is that many of the hospitals that we talk of serving the tier 2 cities, tier 3 cities, they still have machines which are non-DICOM files. Sometimes physicians think that they don't need a radiologist. Networks, bandwidths are still a challenge. And when we provide for a chain of government hospitals in Assam, and one of the questions they asked us is that a radiologist is supposed to be legally liable for the contrast reactions as well. So that is a challenge which we face in India. I would want to bring to your attention a problem which is very India-centric, is that if you report a case in India remotely, and if that image goes to a court as a evidence, for example, somebody has a fracture and that is a court evidence, the radiologist has to go to a court and testify. And now if you imagine the problem that we have in teleradiology is we are serving remote areas. And so if your radiologist gets a call, and I personally had to, go to one of the places to testify, and these places are remote, you understand, there's no air connectivity, no, you go by airport, then bus, then reach there to testify, and then the money doesn't make sense. So what we do now is that in any center that we report, we have an agreement that we are not going to report anything for which is going to act as evidence in the court.
Doctor, we just have a...
Quick. I'm just finishing. I also want to emphasize the utility of tele or medicine or teleradiology as an educational tool. We use my blog and my Facebook groups to disseminate the digital data we keep accumulating from across the country. And in India, we don't get normal cases to report. We get all positive cases, late stage cancer, syndromes. Normal people don't go to hospital. So we have such a huge data that we keep sharing, and that helps us to build up the data. And now there is a talk of technology called as tribogenics. Tribogenics has reduced the size of the X-ray machine, and if that comes up, you might have an X-ray machine size of a mobile phone, and you will have patients taking selfie and sharing to the radiologist for reporting. I would very quickly wind off everything And I will wind off I'll give a summary of the entire thing, that this is the chasm that we all, or everybody of the panel sitting here, all of us sitting together for healthcare IT, this is the chasm that we are all facing. On one side of the chasm is the early market. Early market is by the techies and the visionaries, they take up the early market. And on the other side is the mainstream market, in between is the chasm. Now, if I draw this in a graph, there are innovators, early adopters, early majority, late majority, laggards. Now, I want you to see this picture here, and I want you to understand the gap between the early adopters and the early majority is the chasm. Many people would bring up ideas, technologies, but most would not cross the chasm. They would not be taken up by the majority. That is the challenge we all face. To bridge the chasm, especially for teleradiology in India, we would need more and more government commitment and support. We have to have more and more larger companies to get enabled. It has to be IT enabled. You cannot think of
Doctor,
it
you
from
have
an
just
IT led
30
perspective.
seconds.
Thank you. And we need an overall restructuring of the belief that radiologists should be available on the site. A radiologist can be available anywhere and give opinion. Thank you very much. I'm sorry for taking longer time. Thank you.
Thank you, Dr. Sumer. So we have only 2 questions from the audience. If anybody has any questions, otherwise we'll just wrap it up. Mike, please.
Mr. Sharma, I believe, from Analytics.
Mr. Vamsi. Mr. Vamsi.
Mr. Vamsi, okay. From Analytics, you referred in your first slide about digital prescription. Can you elaborate on that?
No, so I was just asked to speak about best practices, and I refrained from talking about digital prescriptions. The reason is that, see, in the US, SureScripts is mandated for meaningful use, and when Uday was showing that information, the entire thing was there when he was showing that circle with all the points of meaningful use, the mandated thing. SureScripts is mandated out there. So there are countries where digital prescription is mandated. It has to be followed. There are no exceptions to it. But unfortunately, I didn't delve into it, and I can take it offline.
Thank you.
Thank you, sir.
See, actually, there are countries where the prescription is not given to the patient, it goes directly to the pharmacy. So you can take that, and the pharmacy knows what all drugs are. He just traces down the number, and he just gives them that, this is my patient number. The pharmacy already knows what is to be given to him.
So, sorry, I think we don't have time for any more questions. Definitely we can take it offline, or even to take offline. Thank you so much. Thank you.
Thank you, esteemed panelists and chair. Requesting you all to come to the center of the stage for a picture. So, thank you so much. Now we move on to session number 3, our third session for the day on UHC in insurance. Requesting our chair, Mr. Jayasilan Jairaj, board and member treasurer, HIMSS Asia Pacific, to kindly come to the stage. Requesting our panelists, Mr. S.K. Garg, Additional Commissioner, ICT ESIC, Dr. Chandrakant Leheria, WHO, Mr. Nishant Jain, GIZ, Dr. Amitabh Gupta, CEO, Paramount TPA, to kindly come onto the stage.